Good morning. This is Hani Sabor. I'm proud to be invited to the International Young Academy of Cardiology to be part of the session on arrhythmias. The title of this lecture is When is AFib not AFib? Rhythm Control Management Strategies in AFib in Symptomatic Young Patients with a focus on SVT and WPW for early ablation. I'm Hani Sabor. I'm a consultant electrophysiologist working in Abu Dhabi at Cleveland Clinic and an assistant professor of cardiology at Brown University in the United States. The learning objectives to identify arrhythmias that mimic AFib on ECG and unusual presentations, identify lone AFib patients who develop AFib, paroxysmal AFib in young patients, the role of ablation therapy and why it's important to refer early for WPW, disorders associated with AFib that do not have the same left atrial substrate, identify Brugada syndrome as a cause of lone AFib, and the role of sleep apnea as a major trigger for atrial fibrillation. Diagnosis of AFib, the basics. All patients evaluated for AFib should have a detailed history and physical examination to look for the risk factors, particularly CHAD score, and also to look for the triggers. There are characteristic ECG findings in AFib: absence of P waves, irregularly irregular RR interval, generally a narrow complex tachycardia with rates up to 160 beats per minute. QRS duration is usually narrow unless pre-existing bundle branch block, aberrant conduction, or an accessory pathway. Note that fibrillatory waves may mimic P waves, and remember Ashman's phenomenon. QRS morphology can be due to aberrant conduction, abrupt change of the cycle length, and usually these aberrantly conducted beats have a right bundle morphology. In addition, your evaluation should include workup for specific causes: electrolyte, endocrine, especially hyperthyroidism, drugs, infections, drugs or chemical withdrawals, and echo for structural heart disease. So this is atrial fibrillation. You see the fibrillatory waves here are irregular, multiple different amplitudes, and varying conduction. This is in contrast to atrial flutter, where there's a regular sawtooth pattern. Fibrillatory waves, the complexes are irregular, there is no frequency, and the intervals cannot be predicted. Now, note that there are other rhythms that originate from the atrium that can be irregularly irregular. So we have atrial fibrillation, of course. We have AFib with variable conduction. And most importantly, and this is a common mimic that's often mistaken, multifocal atrial tachycardia, as you see here, with multiple different P-wave morphologies and different rates. This is often being misrepresented as atrial fibrillation, and this one does not require anticoagulation. So the differential diagnosis, i.e. ECG mimics of AFib, include sinus tachycardia, atrial flutter, flutter with variable Brock, atrial tachycardia, multifocal atrial tachycardia, WPW, AVRT, AV reentrant tachycardia, and junctional ectopic tachycardia. The last three are commonly misdiagnosed because the P wave is not present. However, as we mentioned before, we do not make a diagnosis of atrial fibrillation simply based on the absence of P wave. There are other criteria, particularly marked irregularity. So let's look at this ECG. This is a nice challenging ECG, and it's a real case. So is this atrial fibrillation? So we have a narrow complex tachycardia. It appears to be irregular. If we look where we should normally see P waves, it appears on quick analysis that there is none. However, let's try to look a little further. I think you see here evidence of group beating, and every so often can lead to a P wave appears. So what is your differential diagnosis? Is this sinus tachycardia with AV Wenckebach? Is it sinus rhythm with junctional bigeminy? Is it AV nodal reentrant tachycardia with 2-to-1 retrograde block? Is it non-reentrant AV nodal tachycardia with fast and slow passway Wenckebach, or is it complete heart block? I'll give you an opportunity to go back and look at this ECG and put it within the differential diagnosis. These are our choices. So in fact, this is the same P wave creating multiple ECG QRS complexes. This is not AFib. So this P wave, as you see, conducts and gives you 2 QRS complexes. This P wave conducts and creates only 1 QRS complex. There is progressive prolongation, block, and then you have again P wave creating 1 QRS and another QRS. 1 P wave creating 1 QRS and another QRS. This is the P wave. This is not a P wave. This is a T wave, as you see here, and it indents the T wave in a specific manner. So this is called the double response or double fire. Even though it's irregular and P waves are intermittently seen, not obvious. So while atrial fibrillation represents the most common cause of irregular tachycardia, there are many other possibilities. As I said, multifocal atrial tachycardia and other SVTs with variable AV conduction, such as atrial tach or atrial flutter with variable block, can be irregularly irregular. Sinus tach with PACs or PVCs can also present as an irregular tachycardia. In this case, the patient had conduction down 2 separate pathways within the AV node with a very long conduction time, demonstrating a pattern known as a double ventricular response. The other prerequisite is that there are no retrograde conduction through the slow or fast AV nodal pathways, since this would result in conventional, typical, slow-fast AV NRT. So let's look at this ECG. Is this atrial fibrillation? So we see a rhythm that is not particularly fast, narrow complex, and we have intermittently a P wave, and a QRS complex that is not preceded by P wave. There seems to be some irregularity, although if you look carefully, you'll see that there is a certain periodic pattern of the rhythm. In fact, this is not atrial fibrillation. These are, again, ectopics with PR prolongation. Where are these ectopics arising from? They're coming from the junction. Again, this is highlighting the presence of dual AV node physiology. So, for the non-electrophysiologists, you'll see clearly marked here that you have 2 different populations of PR interval, 1 long and 1 short, which means that the patient has a fast and a slow pathway, and the presence of the ectopic blocks conduction through the fast pathway, allowing visualization of conduction through the slow pathway. What about this? Is this atrial fibrillation? It is not, because as you see here, there are negative P waves that result in this tachycardia, which terminates to give you sinus rhythm. So if you take a superficial glance at the inferior leads, you might say that it is fast, it is irregular, and there are no P waves visible. But if you look carefully, you'll see that there is an inverted P wave with a different PR interval, indicating a distance away from the sinus and the AV node, and at the time of termination, you can see clearly sinus rhythm resumes. What about this? Is this atrial fibrillation? So after tempting you with all of those complex EKGs, this is definitely atrial fibrillation. It's not typical flutter because the cycle length is very fast, and the cycle length in the atrium is also quite variable. If you look in the inferior leads, again, the sawtooth pattern is not seen. So this may be regularized or more organized form of atrial fibrillation, possibly the patient on antiarrhythmic therapy. And also, one of the important hallmarks of atrial fibrillation is a very wide variation of the heart rate and cycle lengths, and the average heart rate is generally quite rapid. So why do we do pulmonary vein isolation in AFib? Largely because the pulmonary veins are the important source of the ectopic beats initiating frequent paroxysms of AFib. The original seminal work from Michel Hasseguer and the group in Bordeaux showed that by ablating at the ostium of the pulmonary veins, ectopics could be suppressed and atrial fibrillation can be significantly reduced. Technology has advanced significantly at this point. We have access to cryoballoon ablation to seal the ostium of the pulmonary veins electrically, or conventional radiofrequency ablation by drawing a circle around the ostium of the pulmonary veins. Mechanisms and triggers. The most common site for pulmonary vein foci is a left atrial muscular sleeve extending into the pulmonary veins. These cells have shorter refractory periods, and therefore pulmonary vein isolation with catheter ablation isolates this region, further preventing development of AFib. However, as we said, AFib can be triggered by other arrhythmias such as AVRT, flutter, and even PACs. What about SVTs causing AFib? This is a very important differential diagnosis, and when you see a young person with atrial fibrillation in whom there is no structural heart disease and no left atrial enlargement, SVT needs to be considered significantly. The association of AFib with SVT is very well described. It can be occurring during flutter, AV nodal reentry, or AVRT during accessory pathway. Spontaneous atrial ectopy may be a trigger coming from the pathway itself. The clinical relevance is very important because ablation of the underlying arrhythmia can also eliminate AFib, especially in young patients, in the absence of structural heart disease. Several systematic reviews from large ablation centers have shown this. This was published in the Journal of EP. 62 patients with an initial diagnosis of AFib who came in for procedures note that ablation of SVT and slow pathway modification was seen in a small but important number of these patients. A slightly older registry from a large medical center in Greece, again, showed that 409 patients, including the study with atrial fibrillation, at the time of initial EP study, at least 7% of these patients had SVT, leading to ablation of the SVT, made the patients free of atrial fibrillation. Now, back to the ECGs. Is this atrial fibrillation? Look carefully and make a diagnosis. We have a rapid, narrow complex tachycardia, irregularly irregular, interspersed with a PVC. P wave is not seen. Yes, this is atrial fibrillation. Again, we have to consider the most common differential diagnosis, but also not to ignore the others. What about this? What about this rhythm? So in the interest of time, this is in fact multifocal atrial tachycardia. It's very rapid, it is narrow complex tachycardia, it is very irregular. However, when we look in the leads where we are most likely to see P waves, that is lead 2 and V1, you see a P wave, different morphology P wave, different morphology P wave, different morphology P wave. Variety of different P waves, clearly resulting in a QRS complex and driving a rapid tachycardia. In this case, this is a patient with severe COPD and emphysema just prior to being intubated for severe hypoxia. How about Brugada syndrome and atrial fibrillation? AFib is actually the most usual atrial arrhythmia and Brugada syndrome with an incidence between 6 and 53%. The electrophysiological substrate, the channelopathy, responsible for ventricular arrhythmia, contributes to atrial arrhythmogenesis. The presence of AFib is actually a marker of more advanced stages in Brugada syndrome and has been related to a more vicious prognosis. Cusano demonstrated that a syncopal episode, VF, type 1 ECG, were observed in a larger percentage of Brugada patients with AFib than those without. Family history of SCN5A and VF were not associated with spontaneous AF episodes. So, coming back to SVTs resulting in AFib, many case reports have resulted in association of AV nodal reentry with AFib. Untreated AV-NRT is quite common. Most of these patients receive adenosine and do not get referred to electrophysiology. Up to 4% of inducible AV-NRT among patients referred for AFib ablation. Slow pathway ablation abolishes AFib recurrences. French series, 12% of patients with AFib, less than 50 years old, had recurrence of AFib following ablation of a WPW pathway, as opposed to 55% of older patients. Ablation of additional underlying arrhythmias may not eliminate future AFib recurrence in the older patient, and therefore follow-up is required. However, in the young patients, this is a very effective strategy in treatment of atrial fibrillation. From the French registry, taking all of the reentrant tachycardias and atrial tachycardia in one group, AFib recurrence in these patients after ablation of AVRT, AV-NRT, and atrial tachycardia was statistically lower than patients who had atrial flutter ablation who also had AFib. So after adjustment for age, hypertension, and ischemic heart disease, patients with atrial flutter continued to have higher risk of AFib recurrence than patients who have SVT and atrial fibrillation. How does WPW and pre-excitation result in AFib? As you know, pre-excitation is the early activation of the ventricles due to impulses bypassing AV node through the accessory pathway. The majority of pathways allow bidirectional conduction. Retrograde conduction is seen in only 15% of cases, and antegrade only is rarely seen. Tachyarrhythmia is facilitated by a re-entry circuit using the accessory pathway termed AV reentrant tachycardia. Direct conduction from the atrium to the ventricle, seen with AFib and atrial flutter with WPW. And this is the model of re-entry as you see, down the AV node, back up the accessory pathway, although antegrade conduction can certainly occur. It is well known that AV reentrant tachycardia is the most common arrhythmia, and PAF is seen in 1/3 of patients with AVRT and WPW. Is certainly higher than the control population. There are many proposed mechanisms in patients with WPW. Since the accessory pathway has a short refractory period, rapid conduction from the atrium to the ventricle during AFib can result in very rapid ventricular rates up to 300 beats per minute, degenerating into VF, and high risk of sudden death. Most PAF will terminate after successful AP ablation, accessory pathway ablation, and there's a very important role of the accessory pathway in AFib. We generally perform APS to confirm the presence of accessory pathways. As you see here, this is the normal mechanism of pre-excitation. AV reentrant tachycardia can degenerate into atrial fibrillation. Here is a patient with WPW. This is the arrhythmia that they develop when they have orthodromic conduction. In other words, down the AV node, back up the accessory pathway. This is a narrow complex tachycardia, as you see here. So the antegrade conduction is down the AV node, retrograde up the accessory pathway. Results in a rapid narrow complex tachycardia. On the other hand, if you have antidromic conduction, where antegrade conduction comes down the accessory pathway and back up the AV node, this is in a situation where The patient has an AV reentrant tachycardia. This results in a wide complex tachycardia, which looks like VT, as you see here, because there's pre-excitation of the ventricular chambers. Very important, AFib and atrial flutter in patients with WPW can cause sudden death. AFib can occur in 20% of patients with WPW. A flutter can occur in 7% of patients with WPW due to the accessory pathway rapid conduction to the ventricles with high ventricular rates degenerating into VT or VF. The ECG features are rates over 200 beats per minute, irregular rhythm, wide complexes with abnormal ventricular depolarization through the accessory pathway. The QRS complexes change in shape and morphology. However, unlike polymorphic VT, the axis is still stable. So we'll review a case. A 32-year-old male with frequent PVCs and syncope associated with palpitations. So we see here the patient's in sinus rhythm with frequent PVCs that have a left bundle branch block morphology and prominent R waves in 1, 2, and 3. The patient has a very rapid narrow complex tachycardia that is induced by the premature ventricular contraction. During the SVT, the patient spontaneously converts to atrial fibrillation. As you see here, it's irregularly irregular. There are more atrial than ventricular signals, and the atrial morphology and cycle length is totally irregular. This is the surface ECG from the EP study, showing again irregularly irregular rhythm with a narrow complex tachycardia, consistent with AFib. The intracardiac recordings again confirm atrial fibrillation. Completely disorganized right and left atrial signals. This is the ablation catheter. This is the coronary sinus catheter on the left side, consistent with atrial fibrillation by atrial. And this is the induction of the atrial fibrillation. Here you see here a single P wave and then atrial fibrillation occurs again. During ventricular pacing, narrow complex tachycardia is initiated. You see here, this is the V pacing, narrow complex tachycardia. And during mapping, the intracardiac electrogram shows a narrow complex tachycardia with a short RP tachycardia. This is the QRS. This is the retrograde P wave. It's within 30 milliseconds of the QRS. Again, demonstrating a short RP tachycardia. Couple of beats of sinus rhythm, and then atrial fibrillation is induced. So in fact, in the same patient, 2 ablations were done. First of all, the patient had a slow pathway. So ablation of the slow pathway was performed in the classic location of the slow pathway. And you see here, this is the electroanatomical map showing the right ventricular outflow tract, right ventricle tricuspid annulus. Here's the AV node, and here is the slow pathway. After ablation of the slow pathway and the AV nodal entry, attention was then turned to the PVCs, and the PVC focus in the right ventricular outflow tract, the septal wall of the RVOT, was successfully ablated. Post-ablation, the patient had no further PVCs. Pre-ablation, he had 23,000 PVCs, 23% PVCs, no further palpitations or syncope, no AFib on the Holter, no SVT. So the conclusion of this case, frequent RVOT PVCs inducing very rapid SVT, AV nodal entry, degenerating into PAF in a patient with a normal heart. Ablation of the slow pathway and the PVC eliminated both the AFib and the SVT and relieved the syncope. Here's another case. This is a 43-year-old oil field engineer with palpitations and pre-syncope. As you see here, the patient has manifest pre-excitation with a delta wave, a short PR interval, a delta wave that is positive in V2, V3, V4, and V6, and positive in 2, 3, and AVF. The patient was noted on the surface ECG to have pre-excited atrial fibrillation up to 300 beats per minute, consistent with a very high-risk accessory pathway. The location of the His bundle is marked using the His bundle catheter. Coronary sinus catheter is placed, as well as the His bundle catheter and the RV catheter, right atrial catheter. In this case, the patient had a paraHissian accessory pathway, very high risk accessory pathway, in which we note that the actual pathway here, marked in white, is immediately adjacent to the bundle of His, marked here in yellow. And of course, there's a very high risk of AV block. So in this situation, we utilize electroanatomical mapping system and cryoablation. So cryoablation allows you to freeze. We do a test freeze to identify that we are not ablating at the bundle of His. And as you see here, with cryoablation, there's disappearance of the delta wave without AV block and a normal PR interval, almost immediately, as you see here. So paraHissian accessory pathway, a very high risk of sudden death due to pre-excited AFib. So this is sort of a close-up view to show you. So the paraHissian accessory pathway is in fact sitting directly on top of the AV node, as you see here. And here is the delta wave, as you see. Post-ablation, narrow QRS with no delta wave and normal PR interval. So here's another patient. This is a patient with a narrow complex supraventricular tachycardia, very rapid, rates over 220 beats per minute, that terminates with adenosine. So here you see the electroanatomical map. The patient has clear retrograde conduction through the accessory pathway. The accessory pathway is located here at the 6 o'clock position on the tricuspid annulus. Here's the AV node. So the conduction proceeds retrogradely. After successful ablation, you'll see now that conduction proceeds in the normal direction through the AV node after ablation of the accessory pathway, instead of going retrogradely through the accessory pathway. So with that, I will stop. I'm sure there's many questions for discussion. And thank you for your attention.